Hi, all. Welcome back. For this series of lectures, we're going to talk about the adrenal glands, and we'll talk about um, some other things like the pancreas, just other organs that are associated with the endocrine system, um, both which play a really large part in dietary concerns often. So the adrenal glands, which are also sometimes called the suprarenal glands, they occur on the top of the kidney, or kind of like the end of the kidney as a cap. And they secrete quite a few different hormones, some which are really common and important and I think, valuable to know about, and others that might be just helpers or associates of other processes. And so the main purpose is often associated with different things that are going on in the blood, like sodium levels, stressors, some types of sex hormones, things like that. Often the adrenal glands are associated with that. From things like fight or flight response is associated with the adrenal glands and whatnot. And we'll get into those here in a second. Okay. So two main portions, the outer cortex and the inner medulla. We'll talk about the purpose of each. Each kind of has their own set of hormones that they're going to secrete. The cortex is going to secrete steroid-like hormones, often associated with sex, like sex cells or sexual development of different regions of the body, um, sexual arousal in some cases, and we'll cover some other. And then the adrenal medulla is associated normally with fight or flight, and so the two hormones that are secreted in the medulla region are epinephrine and norepinephrine, which you might know them as adrenaline and noradrenaline. This adrenaline and epinephrine it's the same thing. And this is really kind of the purpose of fight or flight, and the adrenaline rush that you get comes from the adrenal medulla. So let's look at kind of this cap. So here's your kidney, that kidney bean shaped organ occurs in your body. The top of the kidney is going to be the adrenal gland, one on each side, as long as you have two kidneys. And then you have two regions. You have the outer region called the cortex and the inner region called the medulla. Now, if we're looking at kind of a cross section of just a small piece of it, it would look something like this. You have this capsule, which is kind of a cap that really doesn't secrete any hormones but protects the regions that do secrete hormones. And then you have the cortex, okay, where we talked about the secretion of a lot of different sex hormones and related to um, things like maybe the chemistry of the blood, like how much sodium's in the blood, or different types of hormonal components like that. Okay, you have three main zones. So the zona glomerulosa, the fasciculata, and the reticularis. And we'll come back and we'll talk about the hormones that are produced in each one of these regions. And then that inner region is the medulla, or the adrenal medulla. Okay, and they have a series of specialized cells called the chromaffin cells, and these are the cells that produce adrenaline and noradrenaline, or epinephrine and norepinephrine. Remember, those can be used interchangeably. Speaking of norepinephrine and epinephrine, okay, These are the chemical models, or the chemical kind of equations, or what they look like from a chemical perspective. And this is kind of the process by which they are made. So tricycline, dopa, and then dopa becomes dopamine, and then dopamine becomes norepinephrine, and then norepinephrine can become epinephrine, or dopamine can become noradrenaline, and noradrenaline can become adrenaline. Okay, these intermediates are important in some situations, from like a disease mechanism, or even some of the medicines that might be needed to entice norepinephrine are dopamine based, like a dopamine beta blocker, or a dopamine beta enhancer might fall in, and that could entice norepinephrine production or decrease norepinephrine production. Okay, but in general, we're just kind of looking at the connection between these two, because norepinephrine and epinephrine are connected to a great deal. Okay, one gives rise to the other, and therefore, in some cases, they are they have kind of the same function, and then in other cases, they might have very different functions. So, looking at the function, epinephrine or norepinephrine, if you were to put this hormone on the heart, or have a high amount of this hormone going to the heart, it's going to increase the heart rate. Either one, so adrenaline or noradrenaline. Okay, so that's just going to increase the rate of contraction. Okay? Other things, so epinephrine typically causes vasodilation, norepinephrine vasoconstriction. Okay, but it depends on the region in the body. Okay, blood pressure, some increase due to the increased cardiac output. Okay, so due to increased heart rate, but you remember you have dilation, so it's opening it up. Okay, the blood pressure went under norepinephrine. You also get some increase due to heart rate, but also you're getting increase due to vasoconstriction. Okay, so it depends on the region. Okay, airways, you get dilation from epinephrine, some dilation from norepinephrine. Okay, and it really, like in many of these cases, you might have an effect, or you might not have much of an effect. Okay, and that really just depends on the region of the body. Okay, metabolic rate, in most instances, when you have adrenaline or noradrenaline, or of course epinephrine or norepinephrine, when you have it in the system, the metabolic rate increases, because normally it's causing increase in heart rate, increase in blood flow, so you need to burn more energy, and so that is kind of that metabolic rate increase. Okay, so the adrenal cortex, when we look at the cortex itself, and we'll come back to the medulla here in a little bit, but when we look at the cortex, remember there's three zones. Okay, the glomerulosa zone, that's the outermost zone. It's typically producing aldosterones and mineralocorticoids, and we're not going to dive into really too much of the actions of these. They can be very important for different things. We will talk about cortisol and glucocorticoids, which are produced in the fasciculata, and reticularis is producing most of the male hormones, and we call those androgens. So we'll talk a little bit more about each of these zones as we progress, and we talk about hormone disorders or complications with hormones. So the aldosterones, just to kind of talk a little bit about this, and kind of how it is generated, or why it might be generated. Normally it's a response to decrease blood pressure in the kidneys or low sodium concentrations. So either one will trigger the secretion of the precursor, so in agostine. So agostine 2 is going to stimulate the cortex, the adrenal cortex, to produce aldosterone. Okay, that hormone is then going to entice the kidney to do a couple things. First of all, it's going to often conserve sodium, so it won't allow sodium to, as much sodium to bind up in the water that's going through the kidney. So it's going to conserve as much sodium and water as possible. Okay? And often it will try to reestablish blood pressure and the sodium concentrations. So this is directly related to kind of the homeostasis of the kidney, which is directly related to the homeostasis of the blood. Okay? Cortisol, of course, this is really important for things like decrease in fats, breaking down of fatty acids, the use and stimulation of the use of glucose. So important for energy matters. Okay? We already talked about kind of these similar pathways before when we were talking about the hypothalamus, the pituitary gland, and the thyroid gland. In this case, the thyroid gland's not associated with it, but you have the hypothalamus, which is going to secrete a cortisol releasing hormone. I'm sorry. So it's going to secrete a cortisol releasing hormone. The anterior pituitary gland. So remember, the anterior side involves blood flow, hormones flowing in via blood. Okay, that's going to release the adrenal corticoid hormone, and then that adrenal corticoid hormone is going to entice or stimulate the adrenal cortex to release cortisol, and then cortisol has a bunch of different effects. But there's also a negative feedback. Too much cortisol is going to stop cortisol releasing hormone and also the adrenal corticoid hormone from being excreted. Okay, so just we've talked about negative feedbacks. This is just showing you a negative feedback. If there's too much cortisol in the blood, okay, it's going to stop this process from occurring. Okay, and then lots of different effects of the cortisol, various different target regions, from fatty acid release, glucose formation, inhibiting proteins from being made, okay, all kinds of different things that's going on. So why does that matter though? Well, there are a few different disorders that are directly associated with the adrenal cortex. Okay? One is called Addison disease. Addison is normally due to a insufficient hormone secretion from the adrenal cortex. So you don't have enough hormones being secreted. And so that often is associated with things like lower cortisol levels. Okay, so you might have lower glucose levels. You might have a problem with too much salt being removed from the system, or which is going to drag the water out of the system, which is going to cause dehydration. Okay, also could have low blood pressure. Remember, this cortex is associated with both kind of keeping the balance of salt, but also balancing blood pressure. Okay, and there's lots of other things. If the electrolyte, salt levels, water levels get so too far out of balance, okay, this can be fatal. And so Addison's disease can be fatal if you're not careful with how you're balancing that material. Okay? One of the key signs for an individual with Addison's disease has to do with skin pigmentation. Okay? And so often you'll have melanization that occurs in regions where you wouldn't typically have melanin forming because they're not associated often with maybe UV radiation, so there's not too much protection, like the tongue, inside the gums, things like that. So dentists often see Addison disease first, and so they'll see a little patch of pigmented skin, and it can be Addison disease in that case. Okay? Another one that often happens is called Cushing syndrome. And Cushing syndrome is the hypersecretion of cortisol, so too much. Okay? Often it's associated with adrenal tumor. There's a tumor that has formed on the adrenal gland, and you're producing too much ACTH. Okay, so adrenal corticoid hormone is too much is being produced by the pituitary gland. Okay? And when you have that, then you have issues because proteins are often so cortisol normally stops protein production. So if you're stopping protein production, you often have issues with your muscles wasting away, loss of bone material. Okay, and then on top of it, cortisol increases blood glucose level, or how much sugars you have in your blood, and so you can have all kinds of things that are going on. It also increases the production of fat. So it increases how much glucose is in the blood, but then how much glucose is converted into fatty acids. Okay, so you get deposits of fat in regions that you normally wouldn't expect, like kind of the back of the neck. Large deposits of fat will form in the back of the neck of individuals with Cushing syndrome. All right, let's switch over a little bit to the pancreas. Pancreas is, one of those we often consider the endocrine system both glands and organs. Okay, and the pancreas is one of those glandular organs that is both involved in helping with digestion, but also involved with uh, monitoring kind of glucose levels in the blood. Okay, so it will transport and deliver digestive juices to the duodenum. The duodenum is the last kind of region of like right when the stomach is dumping material into the intestine. You'll have digestive juices being dumped in from the pancreas. And we'll look at this and you'll see kind of where I'm talking about if you're not familiar. Okay, so there's a couple types of glands. You have endocrine glands and exocrine glands. Okay, the endocrine gland is going to secrete hormone into the body fluids. Okay, and the exocrine gland is going to secrete digestive juices into the pancreatic duct. So one goes into blood, the other one goes into the intestine. Three main hormones that are associated with this. Okay, you have glycagon. Okay, and so glycogen is muscle glucose or muscle sugar. Glycagon is what's going to break that muscle glucose down and increase blood glucose. Okay, and that's secreted by a cell called the alpha cell. Insulin, which most people are fairly familiar with, if you know anybody that's diabetic, okay, you'll probably be familiar with insulin. Insulin is secreted by beta cells, right? And that decreases how much blood glucose is. And it does that by ensuring that the glucose in the blood is actually getting into the cells so the cells can go through cellular respiration and break that glucose down. And somatostatin is going to block both of these. It inhibits both glucagon and insulin. So here's looking at the pancreas, okay, pancreatic duct. So remember, it's going to help with using material from the gallbladder and material from the isolates of Langerhans to kind of produce material that helps digest the bolus that's coming from the stomach into the small intestine. In addition to that, it's going to excrete different types of hormones that get into the blood that's associated with the isolates of Langerhans, okay? And then those hormones can be associated with things like glucose. So two kind of functions. You have enzymes that secrete, or cells that secrete enzymes that help with digestion, breaking down of proteins and sugars and things like that. And then you have specialized cells that are producing hormones, which help with kind of monitoring how much glucose or different things are going on in the system. So two main functions. Okay, so let's look at how that might work. So let's say you eat a meal. When you eat a meal, pretty much any of the meals, whatever you're eating, your blood glucose should go up. Okay, so because pretty much all meals will have some level of glucose, or at least through digestion, some of the things will be converted into glucose. Okay. So blood glucose goes up. Pancreas, there's great blood flow right to the pancreas. The pancreas realizes blood glucose goes up. So when it does, insulin is secreted. Insulin is what allows that glucose to be incorporated in the cell. Okay, the glycogen secretion goes down. Remember, glycogen, glycagon is what converts glycogen, so muscle sugars, into blood sugars. So if you've ate a meal, you don't need to convert that over. And so that will go down. So cellular uptake of glucose increases, and the formation of glycogen will happen if there's any glucose that's left over, which often there is. After a meal or in between meals, your blood glucose level is starting to go down now. So insulin starts to go down. The glycogen secretion will go up. Glycagon secretion will go up, which means your glycogen is breaking down, so you can increase the glucose levels in your blood. Okay? And so the process is just back and forth as individuals progress throughout the day. Well, as many of you know, because I think last estimate was that 30 to 40%, especially if you live in the United States or a developed country, 30 to 40% of people will develop diabetes mellitus some point in their life. Okay, mellitus means sweet in Latin, so diabetes mellitus is, a condition of too much sugar, or in some cases, not enough sugar, or an imbalance of sugar in the blood. All right, so it is often a lack of insulin, so you would have too much sugar in the blood, or you have the inability for cells to recognize insulin. You may have enough insulin, but you might not have the receptors or enough receptors for insulin to be recognized, so the glucose can't move from the blood into the cells. Because of this, you often have issues in different regions. Okay, eyes, heart, kidney, nerves. You can also have many different problems because you have, if you have diabetes mellitus, normally you have enough energy in the system, you just can't get the energy to where it needs to be. So you'll have sugars that are flowing and in blood, but it can't get into the cells. And so we have lots of problems with this. So it can disturb how carbohydrates and proteins and fat become metabolized, because your body recognizes you got lots of free energy floating around, so it may not break down the carbohydrates or the proteins or the fats. So you might continuously build fat, or it might convert proteins to sugars and then to fat. So there's lots of ways at which this can work. Okay, so insulin normally will promote glucose to be taken up by adipose tissues, fat cells, and muscle cells. Okay? If you don't have enough insulin, that goes away. Okay? And so normally what happens is carbohydrates can't enter cells in the normal quantities. Remember, carbohydrates is just a fancy word for sugars. Okay, so the sugars can't enter the cells in normal quantities because insulin doesn't allow for that to occur. So that results in what we call hyperglycemia. Okay, so hyperglycemia is high blood glucose. It's not always that someone is hyperglycemic. Okay, they could be hypoglycemic, meaning they don't have enough blood glucose, and that's often that balancing act between, do you have too much sugar in your system? Do you not have enough sugar in your system? So is your insulin really working? Especially if you take insulin shots, do you have too much insulin? Not enough sugar? There's lots of ways at which this works. Okay, and all of these systems can work in many different ways. You can have weight declines, you can have increased hunger, fatigue, all kinds of things. Of course, if you don't have sugar in the system, then all these things are going to be true. You're going to have a decline in weight, increase in fatigue. Your cells aren't going to have enough energy. Your muscle ain't going to have enough energy to function. You won't grow very well as a child. Okay, lots of different things. You could have lots of glucose being excreted out in your urine, which we call glycosuria. So all kinds of things that can happen. It really depends often on what type of diabetes mellitus you have. Okay, and so that drives us to kind of the types. So type 1 means that we often call this juvenile diabetes because this is genetically controlled, for at least as far as we know. This is due to a mutation, and it often begins before the age of 20. So this is children diabetes, and it's not like they outgrow it. Okay? It means that it was genetically controlled. It's related to often the immune system is destroying those beta cells in the pancreas. Okay, so the beta cells are the cells that are producing insulin. And so your immune system starts destroying them, and now you produce less insulin. Okay? And for the most part, when we say 30 to 40% of people in the United States are going to develop diabetes, we're not talking about type 1 diabetes. This is genetically controlled, and it's part of your immune system. Type 2, on the other hand, is not part of your immune system and is mostly related to, at least we think it's mostly related to, overconsumption of glucose, typically. Okay? Sometimes this is called non-insulin dependent, okay, or mature diabetes. Okay, And so most of the cases are type 2. Insulin might be produced, and you might have plenty of insulin, but your receptors don't recognize it any longer. And this is where that overuse is potential. Okay, we're not entirely sure what causes type 2 diabetes. In some cases, it's clear cut. In other cases, it's not as clear cut why an individual developed type 2 diabetes. But the insulin, it's not a deficiency in insulin. Insulin is produced typically, and the individual just don't have enough receptors or working receptors to allow the glucose to enter the cell. You can still have lots of complications with this. Most of the time, the complications that come with this, because it's in older individuals, it has to do with, like, if you have an injury, you won't heal as fast because the cells aren't getting the energy that's needed to heal that injury. Okay. You can also have damage to the eyes and things like that. Regions that need maybe to heal quicker or need a lot more energy. In some cases, they're deficient of that energy that's needed. Okay. Now, treating it, okay, there's lots of different treatments that are coming about. Both types of diabetes can be treated the same way. Not all type 2 diabetics produce enough insulin. Sometimes they don't produce enough insulin, and so they might take insulin shots too if they have type 2 diabetes. Okay, and it's kind of a case-by-case situation. But treating type 1 normally means that you don't produce enough insulin. Okay, so one of the main things is you need insulin. How are you going to get insulin? Well, for a long time, it was we could get it from cows and pigs, and then you could just use it. Insulin's insulin for the most part. But now we've started to create insulin in the lab, and so you can use human insulin. You generate human insulin by using the genes, okay, that generate insulin, and just placing those genes in a bacterial genome, and then the bacteria will generate insulin in a lab, and then we can get insulin that is human insulin. There can be some issues with pig and cattle insulin, but this is just, it's easier to generate bacteria that can produce human insulin than it is to get it from pigs and cattle. So this is kind of a new approach. Most of the time, insulin is put in the body through injections or kind of a pump, aerosol sometimes. But new delivery systems, because injecting yourself with insulin or having a pump or aerosol form can be problematic. There are new delivery systems where skin patches or creams have been developed. And so smearing a little like lotion cream can introduce insulin into the body. Okay. And then, of course, there are other things that are potential. If your immune system keeps attacking your beta cells, then you could get an isolate transplant, and it's been used in with some benefits, I think. Type 2, often this is diet related, and that's the control that's started. That's the control that's normally associated with it. If diet can't control it, then some of the measures that are used in type 1 might be used. So maybe you produce enough insulin, but it's not enough for the few receptors that you have. So maybe even as a type 2 diabetic, you would take insulin shots to help manage the glucose level that you have. And there's lots of other things. If it's directly related to just overconsumption of food, then gastric bypass or, being on a specialized diet with regular exercise might be mandated and that kind of thing. Sometimes individuals that are type 2 are more like type 1 individuals. It just depends on the individual. Okay, next time out, we'll talk about another system.